Hi, welcome to episode 5 of Pelvic Pain Unpacked. I'm your host, Tamer Hill, with my trusty assistant slash sister slash medical advisor, Dr. Charity Hill. Hello, Charity.
Hi.
All right, your specialty is you're a physiatrist, which means that you're a pain doctor.
It means a little more than that, but it definitely does include pain, and that's been my subspecialty. And so that's what we're going to chat about more in depth today.
Your subspecialty of physiatry, yes. Pain doctor. So you want to tell us a little bit more about what a physiatrist is and then how you got into the subspecialty, just for our
Absolutely.
listeners.
So physiatry is a specialty called physical medicine and rehabilitation. Essentially, the whole specialty is built around maximizing function, minimizing the effects of disability, whether that's pain or a brain injury or a spinal cord injury or amputation. So it encompasses a lot of like a broad spectrum of fields, from hospital, inpatient hospitalizations to outpatient work. And my branch that I've delved deeply into is pain, and more specifically pelvic pain.
So in honor of your pain background, and we wanted to kind of talk about the pain cycle in general, and then be very specific as how that relates to pelvic pain. So you want to dive in? What, because you're the one who kind of helped me create this graphic that I pass on to my medical professionals when we talk about the pain cycle. So do you want to talk about the graphic you helped us create?
This graphic, I mean, it used to be something that I would just kind of like flip over a patient's receipt and like scribble it on the back of it as I was trying to explain, because people are just like, I don't understand. Why am I still in pain? Why is this still going on? And this, the chronic pain cycle applies to anyone in pain. Technically, the definition of chronic pain is pain that's been going on for more than 3 months. And pain varies, I guess, from person to person and from condition to condition. But in general, most people who've been in pain for 3 months will have aspects of all things on this cycle going on. So this applies after you've had ankle surgery, and specifically today we're going to be talking about pelvic pain. And essentially a lot of people are just like, I don't understand. I had my endometriosis out, or I had a hysterectomy. I don't understand, why am I still in pain if the originating cause is gone? Like, why can't I get out of pain? Or if the originating cause cannot be fully removed or cannot be fully treated, how can I get better control of my pain? So this ankle sprain happens, the ligaments tear, inflammation zooms in.
The ankle gets yay big.
An ankle is huge and swollen. So in this scenario, you have connective tissues damaged, you have inflammation already going, and then you automatically end up with body alignment or mechanical changes because you can't put weight on your ankle. So you're already starting to limp. Other things that go on with this are the nerves start sending messages to the brain saying there's
Damage.
There's some damage going on here. We need to alert the brain to let the brain know that something bad is going on here. The brain responds, typically with a protective muscular spasm signal. So it's like, hey, everything clamped down, locked down, let's protect, because the brain can't really tell the difference between a broken leg that might need to get stabilized. This is my guess as to evolutionary why this was an advantage to have your muscle spasm when there's an injury. When the muscle spasm, it actually can, ironically, especially if they spasm hard, they can start pinching on some of the local nerves, and the local nerves can start creating their own inflammation. Also, when muscle spasm down really hard, ironically, it can kind of reduce circulation, as can a large amount of swelling can also reduce circulation just by the pressure of it.
Oh, there's pressure.
There's pressure.
Mm-hmm.
So typically with an ankle sprain, these things start resolving. Like you ice it, you take Advil, the inflammation goes down, those alarm bells to the brain stop going, so the muscles stop spasming. Eventually, as things heal, you start limping, and the ligaments
You start moving your
tighten back up.
toes, you do all your PT, Your sausage toes become normal toes again.
So ideally you resolve within, 6 to 12 weeks. And so that's why that's acute pain. If we take this same scenario and put it into something that evolves into chronic pain, it could either be a more chronic inflammatory condition that's a trigger, like endometriosis, or it can be an injury like a whiplash injury, and things that just get so involved that they don't resolve in time. So when these alarm bells, when the nerve signaling to the brain is going off for a long period of time, it trains the brain to go into kind of like a constant subconscious protective fight or flight mode. And we call that central sensitization. I tell people it's like your brain's been waterboarded with pain, and it's just like, okay, we're just staying on alert 24/7. We are now like manning the station at all hours. We are constantly sending subconsciously
to protect the body. Don't do this because it hurts. Don't do that
Yes.
because it hurts. It's like, and then usually that creates, my experience is like stress. Like if I know something hurts and I know I have to do something that might make it hurt, you like clamp down. Almost like going to PT. Like I know it's going to hurt. I don't, especially for after a shoulder surgery, like they did something to me and I'm like, I never want to come back here again.
Yes.
And then you start guarding it, which means all your muscles like tense up because you know it's going to hurt. And then it just creates this mental block, right?
Yes, and it can be incredibly overwhelming. It can lead to poor sleep. It can lead to anxiety, depression, PTSD-like symptoms, and it can definitely be worsened by what I call medical trauma, meaning you go to seek medical care and you're dismissed or not validated or, told everything's normal and that you should be fine. And that kind of escalates this trauma center in the brain being like, no, we know something's not right, so we're going to keep raising alarm bells. So now to put the chronic pain cycle as far as some of the things we discussed with the acute pain cycle and wrap in the central sensitization. So you have inflammation. Usually inflammation is a part of almost all pain cycles. And a lot of times you don't know what is happening first, chicken or the egg, but there's inflammation. With inflammation, you also end up with neurogenic inflammation, meaning the nerves are inflamed, and nerves can actually create their own inflammation. So that's neurogenic inflammation. Muscle spasm, reduced circulation, poor body alignment, and what I call compensatory injuries. And so you can think of that like, okay, I'm on crutches for my left foot, and now my right knee starts hurting. So those are what I've talked about, compensatory issues. Or people with low back pain who start sitting in a different way to try to make their back more comfortable and end up hurting something else.
Affects their shoulder, affects their neck, affects their toes. Yeah.
And so you end up with these kind of compensatory injuries or strains because you're using your body in a way it doesn't want to be used. And then the central sensitization. So central sensitization is these constant sympathetic ringing alarm bells, PTSD, overwhelm, and
guarding. I like to call it the guarding.
Guarding.
Your body's guarding itself. What were some of the things that you used in addition to physical therapy to help people break this pain cycle?
Yep. So there's obviously muscle relaxants, so it can be oral or suppository form. There's nerve pain medications that there are various ones of those that you can look into. Those can be oral or suppository. Physical therapy, like I had mentioned before, is essential. There's different injection therapies, injections into the pelvic floor muscles or the nerves around the pelvis.
And those injections, I know there's Botox as well that can be used depending on the pelvic pain issues.
Botox, trigger points, nerve blocks. So there's a lot of different types of like interventional therapy like that. And suppositories is one of my favorite ways to deliver medication to the pelvic floor, whether it be a nerve pain targeting medication or a muscle relaxant medication. And if you've heard our other podcasts, you may realize how MedRoots came about. Was us trying to increase access to muscle relaxants and nerve pain medicines to the pelvic floor during the pandemic when we were when I was able to practice medicine across state lines, but couldn't necessarily prescribe across state lines. Because CBD is, even though it's technically herbal, technically natural, it is medication with known effects to decrease inflammation, to decrease muscle spasms, and to improve circulation. So it kind of works on a good chunk of the issues that are main propagating issues in the pelvic pain cycle, and allow the pelvic physios to do the work they need to do to really help break the cycle.